Please allow me to introduce our first panelist, Professor Tuan, the chairman of the board at the University of Medicine and Pharmacy. Welcome. And also telephonically, we have Dr. David Duong joining us via Zoom. So could we also patch him in?
Hi, everyone. I'm so sad I'm not there in person, but really glad to be able to join all of you virtually. Thank you for having me. And thank you, Hawkins, for inviting me.
All right, thank you. Please help me welcome our panelists for this first session. Professor Tuan, so my story of my daughter actually started at the University of Medicine and Pharmacy. It's where we first went to get a diagnosis. So I'm so happy to have this story come full circle. Could you perhaps share with us, for those that don't know much about the University of Medicine and Pharmacy, some of the highlights, the number of patients you see, the number of doctors, and a general overview, please?
First, I would like to thank the organizer inviting me to join this panelic discussion. So my University of Medicine and Pharmacy at Ho Chi Minh City. This is one of the biggest and have a high reputation of medical school in Vietnam. In the South, we can say we are very proud that we probably the best university in health science in the South Vietnam. So our university, we have 7 faculty and 1 university hospital. So for the teaching part, for the education, we have about 1,700 faculty members and staff. In the hospital, we have 3,300 doctors, nurses, and staff. So in education sector, we have about 15,000 students. 2/3 of them are undergraduate students. So it's covered from medicine, dentistry, pharmacy, medical technology, nursing, midwifery, traditional medicine, public health. So that's the area that we cover. So we have 2/3 undergraduates and about 1/3, 5,000, they are graduate students. So including master, PhD, and specialist training. In the hospital, in the service sector, we see about 7,000 patients a day, and we have in total about 900 beds. So, in the past 2 years, because of COVID-19, the number of patients decreasing, but now it's coming back, and we see a lot of patients. It's very crowded in the hospital right now. So just briefly introduce our university, our faculty, and also our university hospital.
Thank you for Professor Tuan. David, you have a very long title as the director of the Harvard Medical School Program for Global Primary Care and Social Change, as well as the director for the Partnership for Health Advancement in Vietnam, and a practicing physician in Boston, Massachusetts at the Brigham and Women's Hospital. So David, could you wrap us up in terms of what you do and focus on Vietnam healthcare? And I would love to hear a story of how you've come to get involved with Professor Tuan and the University of Medicine and Pharmacy.
Yeah, thank you so much, Hawkins. And again, I'm so sorry I can't be there in person with all of you, but thanks for inviting me. So my story with Professor Diep Tuan is so personal, and also meeting him back in 2012, 2013 has really started my career really in Vietnam, and I really owe it to Professor Tuan. So Harvard Medical School has had a 20-year engagement with the Vietnamese health sector, starting with HIV and then expanding to health systems, including medical education, health worker training, and then now primary care. And in 2012 or 13, Professor Tuan was taking a course at Harvard Medical School, and he already had deep relationships with the leadership at Harvard Medical School and some faculty there. And they happened to introduce me to Professor Tuan because I was a student at that time, a medical student at Harvard. And they realized I had a lot of interest in health system strengthening. I had a lot of interest in perhaps even going back to Vietnam to be able to find a positive impact for the country. So they introduced me to Professor Diep, and it was there he was sharing with us his vision for medical education reform, and specifically looking at how we train Vietnamese doctors for the 21st century. And I just remember that his story was so compelling, and his and he had so much passion and charisma for it. And it really motivated me to think about, maybe this is something worth investing time and energy in. Because at Harvard, we had so much opportunity to, work with lots of different types of people and lots of different professors, lots of different research topics. But through the visit with Professor Tuan, and who was also visiting with one of my mentors, Dr. Buck Struhler at the time, we both thought that it would be an interesting opportunity for us to get engaged with Professor Tuan. So it started off with some very small workshops and some engagements, both in Boston and also in Ho Chi Minh City at his university, always around the question of how do we train the next generation of Vietnamese physicians. And then basically it just expanded through Dr. Tuan's leadership and his vision, not just for Ho Chi Minh City, but also for the entire country of Vietnam. It led to a very big World Bank investment through a loan from the Ministry of Health to expand to additional 4 schools in Vietnam to reform the entire way we teach physicians. And that is currently what I'm doing in Vietnam, is really actually to support Tuan's vision and his and really his passion, which has now become my passion as well. And that has then led to other areas such as strengthening the primary care system as well.
Thank you, David. And perhaps we'll segue to you, Professor Tuan. Can you share with us what is your vision and what has evolved in terms of how you've educated physicians here at UMP or elsewhere in the country?
Yes, David mentioned about we met in Boston, and the reason that we think we have to train our doctor in a different way, because when we look at the trends of education, medical education in the world, in the last 100 years, they already get through 3 generations of medical education. The first one is from 1910, after the Flexner report. So we call that the Flexner model. And then by the end of 20th century, when we get to the 21st century, it is the 3rd generation. That is the competency-based medical education model. At that time, when our university reviewed the way we train our doctor, we realized that our model is the Flexner model. It is 100 years ago. Of course, I don't say that our faculty, they always update their knowledge, their skill to teach our students. But the model, the way we train, we educate our doctors, it's a very old model. It's 100 years ago. It's a Flexner model. And then we think probably we need to change the way we train our medical doctor. So we we go around, we visited many medical schools in Southeast Asia and Europe, in the United States. And fortunately, we also get involved with faculty from Harvard Medical School. Like David mentioned, I met Professor Buck Struhler. And he is very interested in this idea and the vision. And we have a chance also to meet with David Duong. At that time, he was a medical student in Harvard Medical School. And then we also have the involvement of HCMC. I don't know whether you know HCMC. HCMC is Health Advancement in Vietnam, an NGO. And many of their, the faculty come from, many of their, the person involved, they are faculty of Harvard Medical School. And they also share our vision, and they really support us. And then we developed the project, and we reported to the Ministry of Health, and we get their support. And then we get a fund from a World Bank. And just last Sunday, I don't know whether you read the newspaper, we have the first batch of graduates. They graduated from the new curriculum just a few days ago, last Sunday. So then David just mentioned we invite all of the witnesses and all the supporters of this project came to join us. And Professor Bergstruller just here last week, and he just back to the United States. So that's a short story about what we had get through in the past. I can say 10 years. We worked together for 10 years in the last 10 years. Yes.
So that sounds like a very pretty story. Could you take us behind the scenes? What was the biggest challenge you faced in changing a 100-year-old system?
You know, we are the second oldest university in Vietnam. And I would say the more traditional university or institution or organization, the more difficult to change. I don't know whether you have the same opinion, but because we believe we already train very good doctor. We have a lot of good doctor in the system. Why we need to change? So that's the first question we have to answer. And we have to convince our faculty why we have to change. And the resistance is everywhere, I think. When you have a new idea, a few person, they will join, they will support you, but the majority will resist.
Yeah.
So we have to convince the faculty inside our institution. We have to convince the leadership in the Ministry of Health. We also have to convince our international partners that they have the same vision and they support us. Because without international collaboration, without, for example, Davis, without his support, I think without international collaboration, we cannot. I think this project would not have happened. Yeah.
And David, maybe I'd turn that question at you. What was your role, and through HCMC's role in changing the mindset of whether it be the UMP leadership or the Ministry of Health? And what would you say is one of the real cornerstones that you're proud of having changed in the system?
Yeah, I think that what our role was to support a vision that we also believed in. So it started off with both of us believing in the same vision, which is that the healthcare professionals in Vietnam the way that they were developed needed to be changed. And it needed to be changed so that they can meet 21st century health needs. Because like Dr. Tuan said, if it hadn't been changed since 100 years ago, those were problems that were in existence that don't happen now. And there's new problems and new challenges now. And the healthcare professionals needed to evolve also. So we both co-believed in the vision, and which was the foundation for Harvard's involvement. And then I think that our role as international partners was to be there with our Vietnamese colleagues as they were going through this change, to really accompany them. And it was, and we use the term collectively that is walking hand in hand, because you can drop an innovation or an idea onto a place, but if you don't work with your partners to be able to think about how to adapt it to the local context, how to apply it to the local context, it might not have such a big impact. And what we did was we really worked with initially with faculty at Ho Chi Minh City, and then eventually to 4 other medical universities throughout Vietnam. and to be there with them as they were going through this to help them adapt. And then as challenges came up, we were also there to troubleshoot with them, or to just offer support. And I think that is something that we're just extremely proud of, that we were able to travel in this journey together.
And David, maybe I have you elaborate. Could you share with us some specifics of skill sets that you saw missing or in physicians in Vietnam, or you see even important today for physicians in Vietnam to develop to address modern patients?
Yeah, so I wouldn't say that they were missing from the old curriculum, but they weren't standardized practice in the old curriculum. So two, or rather three. The first is this concept of professionalism. Vietnamese doctors are professional, and they have been professional throughout their entire, since the beginning of when the country was developing doctors. But was there a curriculum to teach professionalism, to teach students how to engage with patients and not have it be a hidden curriculum, but a formal curriculum? That was one of the things that we worked with our Vietnamese partners to formalize. The second was a new module called Scholarly Project, which teaches students to approach a problem with an innovative mindset. Think about how to solve that problem with a mindset of curiosity and inquiry, and then think about possible solutions, but also think about proper research methodologies in order to answer a question that they may have. And physicians these days, need to be innovative. They need to be able to solve problems. They need to be able to think about patient care issues from multiple different angles. So that's what that course did. And then lastly, I think that we more formally integrated in primary care very early on into the curriculum to have the students see the value of primary care and community-based care, because that is a direction of 21st century healthcare delivery, is focused on primary care, focused on the right care at the right time, at the right place. And that's usually in the community closest to the patients. And most of medical education, not just in Vietnam, but around the world, including in Boston and in the United States, the medical education takes place in the hospitals. So we need to reorient that. And we're doing it here at Harvard, but also working with our colleagues.
Great, thank you, David. So professionalism, scholarly research, primary care. Professor Tuan, do you have any other insights into skill sets that you think are important for the physicians of the future here in Vietnam, and to focus on developing those skills?
Yes, for those David mentioned, it's very important for the new generation of medical doctor. So in our new curriculum, we also, on the process that we teach our students, we also help them to develop some skills. For example, the critical thinking is very important. The teamwork, also very important. So in this curriculum, we have a lot of new things in the country, I would say in the country. And then lifelong learning skill is also very important. In medical sciences, now they say, right now, the knowledge of medical science double every 2 years, the knowledge. And the prediction is the knowledge of medical science will double in 2025, will double in 73 days. So how can you teach all to our students? There's no way. So even we teach, like for the first or second year student, we teach them. And then maybe when they are 4th or 5th year students, something already wrong. So if we don't teach them the way that they can educate themselves, the skill that they provide them as a lifelong learning, so that, like David mentioned, just in time. It's not just in case. In the past, our faculty always want to teach everything. Just in case they meet each case, how can they solve the problem? We have to teach them. But no, we cannot teach them all. So those skills are very important in the way we think, the new way of the new generation of medical education, of medical doctor in Vietnam. And also, like, this is, if we look wider nationwide, our system now although we say a lot, we should focus on primary care. But unfortunately, I would say there's not much effort to really develop this system. And through the the pandemic, we can see our healthcare system really have a problem, overwhelmed. The problem is, we only have two systems. One is the health system. Another one is education system. In fact, the health system should based on the need of the population of a country. And then we say, I need this kind of health worker, this kind of skills, this kind of competence to serve our health system. And then this will inform to the education system, and we will train people to meet the need of healthcare system, and then meet the need of healthcare of the population. But these two systems right now not really communicated to each other very well. So that's the problem in our system. Yeah. So just share with you a little bit about when we mentioned about primary care, and there's still a lot of work to do.
I can see you're very passionate about that. I mean, I guess the corollary to this is, the constant stat that many of us get shown that Vietnam doesn't have enough doctors, and the quantity of doctors is low per capita. And I understand that you raised your tuition in 2020, which resulted in a drop in the number of physicians attending the cohort. So it went from 600 to 400. Curious on, and I want to hear from both of you on your view of, what about the doctor shortage in Vietnam? Is it a quantity issue or is it a quality issue?
I think it's both. First, I would like to, to correct a little bit, maybe misunderstanding. So we increased to 600 medical students a year. We recruited 600 students in 2012 and 2013, in 2 years. And then we realized that by doing so, we cannot handle the number of our students. And after 2 years, we go back to our 400 students, only 400, because we put quality of education is the top priority. So if you look at the number of medical students in other medical school, I think we are one of the best, but we have only 400. For other medical schools, you can see 500, 600, even 800 and 1,000. So it's very different. We put quality as the top priority. So that's the first thing I would like to correct. For the tuition fee, we increased in 2020. It's just recently. And the number of students is still the same. Because we also have the policy to provide scholarship. For those, we try not only put the quality as the priority, but we also try to make access to medical education for everyone, for every student that they would like to pursue in health career. So we provide scholarship for the students. So the number of students is the same, 400. No, the number is not dropped after we increase the tuition fee. But for the tuition fee, I think it's still not enough, I would say. Right now, it's about $3,000 per year. It's not much. And we invest a lot in our education. So if we would, I don't know how to say, but quality, we have to invest. Without investment, how can we improve the quality? So now back to the quality and quantity of the medical doctor. I would say, like I mentioned previously, of course, right now we do have a lack of number of medical doctors in terms of, on population. But the quality of medical doctor is also very important. And to show the problem is if we look at the whole system, there are something other personnel can cover. For example, for the primary care. In other country, the nurse practitioner or physician assistant, they can cover that. Why do we have to treat every doctor everywhere? Because even now, our medical doctor will not go to provincial hospital. They will not go to district, remote area, rural area. They will all base here. If we would like them to stay there, maybe we need another kind of health workers. So what is the competence that we need to serve the whole country? That's why I say we need to base on the need of the health system. And then what kind of competence that we need. And then we have to inform the education system to educate and provide those health workforce. So I would say, to solely answer your question, we lack of quantity and also the number, also the quality of our medical doctors.
Safe answer, safe answer. Yeah. David, do you have an assessment here?
Yeah, I would agree that Vietnam needs to focus on quality and it needs to focus on quantity. But I think this is where innovation and technology can come into play, right? So we could really think about technology to help improve quality of care. Majority of healthcare can be via algorithms. For example, a patient with diabetes or stage 1 or 2 hypertension, etc. It's very it can be driven by algorithms, and it can be driven by algorithms that you don't necessarily need a doctor to do. It can be a nurse practitioner, it can be a nurse, it could even be a family members that we're seeing in some countries. So this is where technology can help us bridge that quality gap. And so then we can focus on the quantity because Vietnam definitely needs both.
Got it. Thank you. So it's both a quality and quantity issue, and it could be augmented by technology. And, switching maybe into the role of the public sector vis-a-vis the private sector, I think the general understanding is that the best doctors in the country are in the public sector. Have you experienced any brain drain into the private sector? And will there be a war for talent in the future?
Yeah, sure. Right now, in the last 2 years, many nurses and also doctors move from public sector to the private sector. And if the public sector doesn't have another, to rethink of our system, if we go through this way, I think we will weaken the public sector. The health, right now, most of our health service, is provided by public sector. And many good doctors, they stay in the public sector. And even in our university, we also try to provide a very good working environment. But some of our nurses, faculty, also already moved to the private sector because they have better pay, and many other reasons. So, like you say, brain drain, yes, it's happening now. And I'm sure it will be even worse in the future. Yeah.
Can I ask a controversial question on the monetary issue? What's your view on doctor pay? And it occurs to me that doctor pay in the public sector is incredibly low to retain that type of talent.
The payment, the salary of our the doctor in the public sector is really cannot compare to the private sector. It's pretty low. But for our faculty, fortunately, because most of our faculty, they stay in the university because we try to provide a working environment is good. And also many of them, they don't really survive based on their salary. So they earn from different sources. For example, they have their own private clinic. So they build up their reputation, their skill in their profession, and then they have their own private clinic. They also see a lot of patients. So right now it's still fine for us, but if Yeah, but things may get worse in the future.
Thank you. And I'm conscientious of time. I'm going to ask one more question and then open up to the floor if anyone has a question that they would like to ask our participants. And so maybe I can ask, if you have any sort of views on the lasting changes of COVID and how has that impacted UMP and care delivery in Vietnam. And, David, perhaps segue and hear from you as well first on this. And, you might be seeing how care has adapted, from the United States and how that might be applicable here as well. So I'd like to hear from both of you on that. And then I'd like to open up to the floor to see if there's any questions that the audience might have.
Great. I'll be happy to take this question first from a global context, and then I'll give some Vietnam-specific examples, and then Dr. Tuan can talk more. So I think from COVID, what we've learned, again, is the countries that performed the best during COVID had very community-based and primary care-based approaches. So the countries that had the lowest mortality and morbidity, if you control for other factors, really had very strong community-based approaches. So like we've been saying before, primary care and care at the right time, at the right place, is going to be what we're looking at for the future of health systems globally. The second is that technology is going to come very much into play. The medical system was very hesitant to adopt technology prior to COVID, but because of COVID, now our use of telemedicine, teledoctors, et cetera, has really been, that world's been opened up, and we're trying to be able to open it up even more. So I think anything that allows for the use of telemedicine is going to be very big in the coming years. And then finally, I think patients now are getting used to being in control of their own health information and their own data and generating their own health data. So that means, for example, COVID allowed us to self-test at home if we had COVID or not. Patients were getting much more medical information than they normally were and able to process that medical information. Now, whether that information was right information or wrong information, they were still receiving a lot of medical information, and they were actually becoming the owners and the experts for their own healthcare. So we as medical professionals and the medical industry need to be able to recognize that and be able to work with patients who come in with their own medical information, their own medical data, and be able to utilize that. Case in point, a lot of people are using wearables. They're using their iPhone to track, their number of steps, their heart rate, their blood pressure, et cetera. Patients, so we need to be able to use that and absorb that. So those are, I think, the three big trends I would say globally, and I also think here in Vietnam in terms of the healthcare environment post-COVID.
That's really exciting. Thank you for sharing that. Professor Tuan, lasting changes at UMP post-COVID.
Yes. So let's say the change in education first, and then in the service. In education, there's always in Vietnamese we say nguy cơ is the risk. Nguy is dangerous. Cơ is opportunity. So when COVID come, before that, when we encourage our faculty to teach online, using online material, develop online material, teaching material, it's very difficult. But with COVID-19, everyone involved. And then through 1 year, now they are very skillful teaching online. And now they prefer to teach online, even prefer to teach online. And even meeting, they say, okay, can I just join like David today? So if you cannot come, you can just join online. So that's a good thing. And during the COVID-19, of course, we train our students using online virtually. For service, yes, technical is very important, and we can use telemedicine, all of those things. But in Vietnamese healthcare system, I think that I still have one concern. I completely agree with what David just mentioned. But in our system, because our system rely heavily on tertiary hospital. So the big hospital, in the provincial hospital, and also in the hospital in the big city, like Ho Chi Minh City in Hanoi. I don't think we have health workforce, I mean medical doctor, they have time for other activity like telemedicine. If we don't try to set up our system to have, more patients take care in the grassroots level, and our doctor here have more time. You know, our doctor right now, they see a patient only 3 to 5 minutes to one patient. Do they have time to do telemedicine? I don't think so. And because we rely heavily in tertiary hospital in our system. So we can only do that if we can have more release burden to tertiary hospital, to a more primary care system. And then we have our specialists, the best doctor can help our patient in more rural area, remote and rural area through telemedicine. Let me share with you, I was just with David in Miami University 2 weeks ago. And I met one our colleagues from China, and he said, if you want to see our best specialists in Beijing, on Friday evening, you go to the airport, you will see all of them there. They will fly to all other cities to help, to do surgery, to provide consultation everywhere. So our system also, if we would like to do that if we don't have time, how can we do that? So the burden should be released, not in tertiary hospital. I think we have to set up that kind of system. Right now, I think it's very difficult. Although I completely agree with what David said, but our system, we have to change a little bit here.